Hi, my name is Dr. Anucha Apisarnthanarak, and today I will talk about the Antimicrobial Stewardship Blueprint, which was developed by Asia Pacific AMS Working Group and served as a practical user guide. First, what is the MS Blueprint? The MS Blueprint is a toolkit developed by a working group of infectious disease experts across Asia to help Asian hospitals develop, implement, and improve antimicrobial stewardship programs. The toolkit is sponsored by Pfizer, with all the content developed and endorsed by MS Working Group experts. The goal is to help guide Asian hospitals to implement MS program and to simplify the process. The MS blueprint contains material from MS program leaders, the team members, and for the outreach with Hawaii, a practical guides and suggest some adaptation template and outreach material as well. Most items in the MS Blueprint contain hyperlink for the user to easily navigate from one document to another and to link to online material as well. This is the photo and the name of the MS expert that participating in the MS Working Group, which helped develop and partnership with the MS Working Group as well. So how does the MS Blueprint stand out from other MS offering? First is this an interlinked nonlinear tool, which was developed for Asian hospital with inputs and endorsement by regional MS experts. It fit for multiple audience types, including the MS program leader, the MS team members, and for the outreach as well. And also it can be customizable and practical templates. Give some example and also the leaflet for the hospital to tailor to their own use. Also, it help encourage partnership and communication within the MS team and with other hospital stakeholders as well. It is also very flexible, deliver format electronically and also in printed as well, which at the end it is very easy to update and easy to add more content on this MS Blueprint as well. What is in the MS Blueprint? First, the MS Blueprint is divided into 4 key parts. First is the introduction part, which are demonstrating a brief overview of MS Blueprint Toolkit. Second is the MS Lead, which help guide and resource for MS leader. And third is the MS Team, which guides and resource for the MS team. Fourth is the MS Outreach, which contains the material for the outreach about the MS for the hospital and the patient as well. How to use the MS Blueprint in your hospital? We suggest to use the MS Blueprint to start with 4 steps. Step 1 is to read the introduction for a brief overview. Step 2 is to assess the MS status using the MS checklist to identify MS components that need to be addressed in your hospital. Step 3, use the toolkit to establish or develop a functioning MS program. Serve as a practical guide and resource to establish and develop a comprehensive MS program in your hospital. And step 4 is to spread the word. Use the outreach materials to educate hospital personnel, patients, and caregivers about the MS program as well. For step 1, it provides the overview of the MS Blueprint. This is for the MS leader that I will spend a little bit more detail to talk about this. Second is for MS team, which have some more components that I will talk about this later. And also the MS outreach, which has a lot of components as well. For step 1, the overview of MS Blueprint material for MS Program Leadership, and this component contains the Hospital MS Program Assessment Checklist, a guide to implementing MS program in Asian hospital, and also how to deal and challenges when implementing MS program, and also developing hospital-specific guidelines for the use of antibiotic in adult patients, and diagnostic stewardship in Asian hospital, as well as effective leadership and communication for MS program in Asian hospital, and lastly, a guide to sustainable management of MS program is also included as well. For step 1, overview of MS Blueprint, the material for MS program leader. The first and one of the most important is MS program assessment checklist, which serves as a checklist to assess what aspects of MS program are already in place and which area need to be addressed. It can be used as a companion to a guide to implementing MS program in Asian hospital. Second is a guide to implement MS program in Asian hospital, which provide a practical step-by-step guide to implementation of MS programs in Asia for MS program leaders. Additional resources to go with the guide, including the appendix of useful online link to guideline and toolkits, and a case example of successful MS program in Asia hospital, and also MS program business case slide, which can be downloadable PowerPoint that the audience can use and download for free. Dealing with challenges when implementing MS program is also included, with including the content of the use as a supplementary item to a guide to implementing MS program in Asian hospital. It includes suggested strategy, case example, and experience sharing to address some challenges faced by MS program leads and team in Asian hospital, and also developing hospital-specific guidelines for the use of antibiotic in adult patients. And this guide is intended for hospitals that do not yet have their own hospital-specific guidelines. It includes the step example of guidelines and example template to develop hospital-specific guidelines for some common infectious disease syndrome. Diagnostic stewardship in Asian hospital. This guide is on how to effectively drive diagnostic stewardship as an important partner to MS program, and also it contains the effective leadership and communication for MS program in Asian hospital, which serve as a guide for MS leader on how to effectively lead the MS program, as well as a guide to sustainable management of MS program, that once an MS program has been established, this guide provides tips and pointer on how to sustain the program in the long term. Step 2 is to assess the MS status, and this is one of the most important components. Using the MS checklist is to help identify aspects of MS that need to be addressed in your hospital that broken in many aspects, that you can referring this to my talk. For the assessment of MS program using the checklist, the question tag C, tick blue, are considered essential or core components of MS program, that including 12 core questions, and also the question tag S, tint pink, are considered additional or supplementary components of the MS program that contain 20 supplementary questions. The core component is the part that you should focus first on ensuring all the essential elements of a functioning MS program are in place, and is tagged in C, and your duty is to answer yes or no as shown in this PowerPoint. The example pathway from AMS checklist to a guide. If you answer no to any of the core component question, the following links in the AMS checklist to the relevant AMS Blue guides and resource will be available as shown in this PowerPoint. If you tick no, it will link to an appropriate guide. For example, for hospital leadership support, it will referring to a guide to implement antimicrobial stewardship program in Asian hospital, and also a guide to effective leadership and communication for antimicrobial stewardship program in Asian hospital. The guide contains a lot of aspects, including the example component, the AMS business case example, and AMS business case template. In case that you need to have a guide on implementing AMS program in Asian hospital, and also for effective leadership and communication, it contains the example content and the link to the online resource as well.
Thank you, Anucha. So it made very clear. So now I would like to add a few more components to what Anucha has already informed you. This is about the using of the toolkit. So there is a saying that you need to work hard, and some people say that work smart. So that makes a difference. So either you work hard or you work smart, you can achieve 90%. When you use both, working hard and working smartly, you can achieve 99%. So to achieve the best maximum, what we always look forward is to get more tips and tricks. So you definitely need some coach or advice or guidance. So that is what we are trying to achieve by providing you the toolkit. This toolkit has been developed by the experts with experienced, well-accomplished people from across Asia Pacific region. So they sat and met many times, at least 4 times over 2-3 years, and they deliberated, brainstormed, and they brought out this toolkit manual. So which is readily available for the end users who are practicing antimicrobial stewardship. And under this antimicrobial stewardship toolkit, there are 8 different components has been identified, and for each component, the guidelines or the tips has been added. And this is the collective toolkit. And you can see in this slide, we have mentioned about this 8 component. One is the performance of the situation analysis. What is the prevailing situation? Identify the gaps and challenges to that area. So that is the first and foremost. Second one is obtain approval for antimicrobial stewardship activities. That is coming together. Our beginning is the most important one. Who should be there? What kind of expertise is required? And what is the individual's roles and responsibilities? So we call this as a team and team leader and the communication. That forms the third component. And what this team is going to achieve, how this team is going to implement. So you need to set the goal. So at the end of the year, at the end of the meeting, how different staffing or the doctor, nurses, pharmacists, what they will learn, what they will implement, and what will be the desired outcome, and what is the timeline. And what are all the interventions is required. Especially this is aimed at the prescribing physician, where he will be talking about the choosing about or understanding about choosing the right antibiotic, dosage, duration, therapeutic drug monitoring, follow-up, feedback. So that kind of information, or de-escalation, streamlining of the antibiotic, and what kind of results he expects from the microbiology at the earliest, and how he can effectively develop an antimicrobial stewardship, and how he can continue to evolve the standard treatment guideline and antimicrobial stewardship, and how he can identify an outbreak. This kind of information where the physician intervention is required for the betterment of the patient outcome. So those things will be there. And whatever the steps he is following, how to monitor that your actions are paying. That we call it as key performance indicator. And for different component can be measured or validated using the key performance indicator. So those informations can be obtained from this manual. And the next one is how to continuously sustain the activity what we have achieved, and how to continue to improve the situation can be done with implementing, educating, and continuing to train all stakeholders of the hospital healthcare industry. That comes out in this seventh component of this toolkit. And the last one is, as I mentioned to you, all put together how to sustain and continue to improve. So these are all the various toolkits, guidance, coach you will get to improve whatever you know earlier. So briefly, I will give some examples. Of course, the antimicrobial stewardship should have definitely a physician as a leader with the pharmacist assisting all the time. And this is called they are the most two critical important people playing the antimicrobial stewardship leadership and the communication. And they should be aptly supported with the clinical microbiologist, infection control, and the data needs to be analyzed, generated, and should be presented by the IT expert to the core team of infection control, clinical microbiologist, physician, pharmacist, and the clinical pharmacist. And the support for this core team is hospital administration, hospital epidemiologist, and other physician pharmacists who are stakeholders of the healthcare settings. And what are all the important detailed informations are available for how to prepare a cumulative antibiogram, and when it is significant, when it is not significant, when to intervene, or when to dump an antibiotic and move away from polymyxin or carbapenem sparer or colistin sparer. The next one is what are the key performance indicator and how that is helpful to validate, and those various key performance indicator and their interpretations are given in another guideline. And the role and responsibilities are pharmacist are given, and in another book, what is the roles and responsibility of the nurses to contain the antimicrobial resistant and to enhance the susceptibility or cure of the patients is given in another tool manual. So one exclusively for the pharmacist, another one exclusively for the nurses are written up. And in the hospital antibiogram, the data of the drug usage and the antimicrobial resistant profile and how to choose various criteria to include into the data. It's all detailed, and the Excel sheets are provided, and how to use and what to look for guidance are given in this manual. And similarly for KP also, it exists. Okay. As I mentioned to you earlier, a separate detailed pharmacist guideline for Asian hospital and for nurses for their role and responsibilities are given in another toolkit. So in addition to this core team of nurses, pharmacists, ID, and the physician, there are many other stakeholders are there for the appropriate and apt use of antibiotic. The biggest chunk is all the doctors who are prescribing the antibiotics. So all healthcare physicists, surgeons, they do prescribe antibiotics, and they should know why they are giving antibiotic, what are the do's and don'ts, and how to streamline the antibiotic, when to escalate, when to de-escalate, when to avoid duplicating or antagonistic antibiotics. So that kind of detailing are given for the physician in a separate manual. And when to step down the therapy, how when you can move from IV to oral switch, and what are the best alternative antibiotics available. So achieving the same PKPD are given in another manual. And each one responsibility, if he doesn't follow antimicrobial stewardship, what will happen? For the individual, for the hospital, for the patient. That is given in a separate manual. And wherever there is an antagonism where two different antibiotics or two different medicines not necessarily antibiotics, which will cross-react as been mentioned in this manual. And who are all the stakeholders of containing and making good use of antibiotics? Those individuals, do's and don'ts, are given as a poster for the constant reminder and education. And there are other patient leaflets are available where the patient should unnecessarily should not demand for antibiotics. And if the doctor also should know when to give and when not to give. Sometimes it's better if they explain and protect the patient for knowledge and for the everyone's general knowledge. Appropriate posters can be put out in the every hospital or in the corridor where the patient resting or waiting areas are there. These are all the reach out programs. And especially for doctors, I would like to re-emphasize always, majority of the time, in an empirical therapy situation, without knowing the identification of the organism and susceptibility profile, the chances of error are very high. Only when you know the ID of the organism and susceptibility resistant mechanism, you can achieve target therapy. So always be open to change the antibiotic and de-escalate if it improves. And minimal use of antibiotics are very, very important. This is one of the very central component of the antimicrobial stewardship. And as I mentioned to you earlier, the hospital leaflet, hospital posters has to be continuously provided, educated, because these are all the areas where there will be a high turnaround, footfalls will be there, and they get an opportunity to understand and follow for the betterment of the healthcare people. So same thing, what I mentioned to you earlier. So this is my last slide. The question is, in many centers, they will already have this kind of toolkits in place. In why they do need this blueprint? Because it's not an end, it's not a static document forever that will be the answer. You need to constantly evolve with the new information, new addition. So the constantly our approach and attitude, behavioral change are required to further our containment of antibiotic resistance. So it's not a static document. Every time there will be modification and improvement in the document information. So it's very important, even though you need to constantly keep upgrading and improving the blueprint. So that's why periodically that needs to be reviewed and new information needs to be included. So with that, I would like to end my talk. Thank you very much.